Good afternoon. My name is Melanie Escher with the Arizona Telemedicine Program and Southwest Telehealth Resource Center. Welcome to today's webinar. So as you join today, just a couple of tips and notes. Your microphones or your phone were muted, so please go ahead and use the chat feature for any questions, Q&As. We can get to those. There will be a post-webinar evaluation. Please go ahead and fill that out, and the CME credits can be obtained through that evaluation. So everybody that has joined us today, I sent this in a previous email, so I don't need to read through it, but this has got our CME information. We've got our outcome objectives, accreditation statement, and of course the relevant financial relationship statements for the continuing medical education credits. Hosted by the University of Arizona's College of Medicine. Standard disclaimer. Take a note of that. And again, please check out our website for upcoming webinars and events. I will have a thank you email to everybody that's attended today, and this will have that information in it as well. Also, along with the link to the evaluation, although it will pop up in a window behind this webinar. You'll have a URL will pop up automatically, and you can complete that evaluation. It just takes a few minutes. And again, your opinion is valuable to us, so please go ahead and do that evaluation. There's a code in there to text for CME credit. I'll have that information in the thank you email as well if you don't have an account with the College of Medicine's Cloud CME account. It's very easy, very simple to do. And this webinar is made possible through funding provided by the Health Resources and Services Administration, the Office for Advancement of Telehealth. So today we have with us the state of the science on therapeutic alliance in teens using telemental health. So Allison is with us today. She's a PhD candidate, and she is coming to us live from Philadelphia. And although she is a student here at the University of Arizona in the College of Nursing, I'm going to go ahead and stop sharing so she can get her slides up, and I'll do a little intro for her. So Allison is a psychiatric mental health nurse practitioner with over a decade of experience providing mental health services across the lifespan. And like many providers, Ms. Urkel has shifted her practice to telehealth during the COVID-19 pandemic, but found many adolescent patients struggle with communicating and connecting with their providers during telehealth session. So this experience served as a catalyst for her wanting to understand adolescent perspectives of telemental health. So without any further ado, I'm going to go ahead and pass the mic on over to Allison, and Allison, take it away.
Hi, thank you so much. Yes, my name is Allison Urkel. I'm a psychiatric mental health nurse practitioner. So what I'm going to discuss today is based off of a scoping review that I started my experience during the COVID-19 pandemic with using telehealth in my practice really spurred this idea of wanting to figure out why adolescents were struggling to connect with their providers during our encounters. And so I worked with a team of 2 other people, and we completed a scoping review for this. So I did list the outcome objectives, just like Melanie had already shared, but hopefully I'm hoping people to walk away today really understanding what Therapeutic Alliance is, how it actually can be measured from both the patient perspective and the provider perspective. From this scoping review, how we found there are multiple factors that can impact the Therapeutic Alliance for the teenagers that are using the telemental health, and then some potential limitations. An overall recommendation was using a hybrid approach that is offering both in-person and telemental health encounters for teens, but how that can be a limitation for many teenagers who are seeking care. Just for some background, I wanted to define some terms so we're all on the same page. So Therapeutic Alliance is a concept that has been around in psychotherapy since the 1970s. It is describing a collaborative relationship between the patient and the provider. There are 3 concepts that make up the overall encompassing Therapeutic Alliance. The first one is the strong, effective bond. I think that's probably the first thing people think about when they think about a therapeutic alliance is that relationship bond. But the two other components are agreeing on the goals of overall treatment, what the person wants to work towards to feel better, but also the agreement on tasks that they need to achieve during the encounter to work towards those goals. Therapeutic Alliance, as I said, has been around for a long time. It's actually can be applied to any type of therapy or any type of encounter, and it's the biggest predictor of therapeutic outcomes. So a stronger therapeutic alliance is a great indicator for a positive outcome for the patient. Telemental health, I know there's a lot of definitions out there, such as telemedicine, telenursing. We decided to use the term telemental health to be all-encompassing, meaning that any mental health professional who is providing services to a patient who's seeking mental health services could be listed under this. That way, in the scoping review, we weren't really limiting ourselves to any one profession or for any type of singular disorder. The other definition that we decided to go with is that it's a synchronous encounter. There has been an exponential increase in telemedicine because of the pandemic, or during the pandemic, I should say, rather. But there's also this other increase in use of like chats. They can either be synchronous or asynchronous, emailing or texting or whatnot. But for our scoping review and the state of the science here, we decided to focus on synchronous real-time encounters. It could include audio only, which is like a telephone, or with a video such as Zoom, or there's Doxy.me. There's a whole bunch of platforms that include audio and video conferencing. Then the defined age for adolescents here, we chose 14 to 18. Adolescents can range from 13 to 21, which is, important for, psychodevelopmental stages such as Erickson. That's really when the individual is trying to understand their identity. They can feel more comfortable, and I feel like the parents or caregivers push the adolescent to be more active in their care, their health care, so that they provide more information during the encounters and are more engaged. The age of consent for treatment in the US varies by state. It's often around 14 to 16. So I chose the age 14 to kind of capture the youngest to the outer cuff of 18, which is the age of majority in the US. So just a little bit of significance on this. I mentioned how I'm a psychiatric nurse practitioner. I work with clients across the lifespan, including teenagers. Adolescence is a really vulnerable period of time for overall health, but also mental health. And 1 in 5 teens reported experiencing a severe mental health disorder in the past year, according to the latest CDC statistics. And 50% of lifetime mental health problems begin by the age 14. So that's, again, that age where they can start to consent to their own treatment. They don't need a parent or guardian to sign them up for mental health treatment. That's really to help improve access to care. However, of all these individuals that are experiencing mental health issues, only 50% are receiving treatment. And that was based on another review that came out recently. The impact on mental health issues has a wide range of impact, can lead to school absenteeism, risky behaviors such as substance use and engagement in sexual activity. It can also lead to suicidal behaviors and threats. So telemental health can really increase access to care. Again, this age group is really important because you have a great loss of potential. If, the teenager isn't attending school, then they miss out on receiving their high school diploma. And then that kind of sets them up for lower expectations for the rest of their life. So the issue I found in my practice and in discussing with colleagues at the time before I started on this dissertation journey, it has been supported by the literature, as we'll see, but many adolescents found that telemental health did not meet their needs. There was a preference for in-person appointments, both during the pandemic when the physical distancing was either mandated or encouraged. And so, but even now, I feel like many providers are continuing offering telehealth, but many of the teenagers prefer to come in person. This happens in my practice all the time. A teenager will ask to meet first in person, and then they say they can go continue care with telehealth, but want that first in-person relationship to be established. So I really wanted to figure out why this happens so that we can address how to improve it and really meet our patients' needs. So the research question that we had to kind of incorporate all this was, how does telehealth as a means of interaction impact the therapeutic alliance between adolescent patients and their mental health providers? I can provide the full search strategy if necessary on request, but essentially we started with 3 databases: PubMed, Embase, and PsycInfo. That was back in fall 2022. Then in the summer of 2023, we did add more. Oops, sorry, my mouse moved that. We added CINAHL, ProQuest, and Google Scholar. I did an informal update for my dissertation in the fall of 2024, but that only added 1 more novel article. But anyway, so we started off with 1,091 unique articles based on our inclusion exclusion criteria, made it all the way down to 9 articles total. A lot of the articles were not included because it was from the perspective of the provider, the clinician's experience of Therapeutic Alliance on behalf of the adolescent patient, but we really wanted to take a look at what the adolescents themselves were experiencing during their telehealth encounters. I did want to note in the inclusion-exclusion criteria, these were peer-reviewed articles, except when I added ProQuest, we excluded quality improvement projects. So it was really just focusing on the dissertations, which have 3 PhD scientists on the chair approving dissertations. So it wasn't quite peer-reviewed for the Gray literature, but for everything else it was. So as I said, there's a total of 9 articles. They came from 6 countries. We combined the ages of the participants to make sure that they really were in that 14 to 18 range. Some articles really grouped in like children, like 6 to 21. So I added up all the participants. The mean age yielded just over 15 years old. 3 of the 9 articles took place prior to the COVID-19 pandemic, and 2 of those were one-time consults about the feasibility and acceptability of telehealth for like a psychosocial assessment or a consultation. It did measure the therapeutic alliance between the provider and patient, but I just think it's noteworthy to say here. There were qualitative and quantitative studies, but the most often the scale was used was the working alliance inventory for the quantitative studies. So we had to do a deep dive into everything. With the working alliance inventory, that's been used since around 1985. It has been validated to be used in children and adolescents. It has not been validated to be used in telehealth. However, it has been validated to be used in the e-health, such as like the asynchronous chats, which I found to be interesting. But the working alliance inventory has a total score measuring therapeutic alliance plus those 3 components of therapeutic alliance: the bond, task, and goals, and they're divided equally. It's not standardized, but a higher working alliance inventory score means a higher therapeutic alliance. The other ways that they discovered therapeutic alliance in the qualitative studies was through their analysis. So they were rigorous studies. It wasn't just like a case report discussing therapeutic alliance. The 10th study that I included in my dissertation, but the scoping review was already put into print at this point. It was specific on anorexia nervosa. So I will discuss that when we talk about the themes that we found. But I wanted to focus on the 9 articles there. So we did discover 5 themes after extrapolating all of the data. Again, it was a team of 3 of us. The 5 themes were, and I will go into depth of each one, is the established relationship prior to shifting to telemental health, which diagnoses are best suited for telemental health, technology's role in telemental health, the importance of therapeutic space and privacy, and appointment attendance. So for the first theme, the established relationship prior to telemental health. So these articles, the 4 of the 10 articles, discussed how the initiation of therapeutic alliance in person helped to maintain therapeutic alliance when they transitioned to telemental health. So these 4 articles took place during the COVID-19 pandemic, often when the public health emergency was in place and physical distancing was mandated. So people had access to their providers, but through telehealth. So there was some mixed reviews from providers, because we did look at what the clinicians reported also, and in addition to what the adolescents reported. But clinicians reflected that they may have to extend a greater effort if there's no established therapeutic alliance, because they wouldn't be able to, as opposed to in person, they would not have the physical contact. Eye contact has to be stimulated through the video, and there's difficulties expressing nonverbal communication. Another aspect was that there's less preamble before starting the clinical work, less hello and goodbye while you're walking back to the private room. Instead, you just start immediately once the camera's on. And they also found in these articles that those that didn't have a strong therapeutic alliance tended to end sessions once they transitioned to telemental health. So essentially those clients dropped out to care. There were some mixed reviews because from the adolescent perspective, some felt they could become more vulnerable during their telemental health encounters. Clinicians reflected on that as well. There wasn't a consensus on why that was. Some felt like the clinicians could see into their personal space and vice versa. There was some reports of like hearing a therapist's dog bark. So then the adolescent talked about the dog and that got them to open up a little bit more. So there wasn't exactly one definitive reason why it might help them become more vulnerable. But they did concur that having this relationship prior to being in person made their relationship stronger, or at least the same when they went to telehealth. The next theme is on diagnoses that are best suited for telemental health. Again, there's no consensus on this. However, one of the studies, the Mercury study from Israel, they did a correlation between the working alliance inventory and a few scales, such as the pediatric symptom checklist and depression anxiety scale. So they found those with more internalizing symptoms, the individuals that tend to worry more, or more sad, and experience more negative emotions and thoughts and feelings, as opposed to expressing them externally. They had lower task and goal subscales. So that made their therapeutic alliance lower. Then on the depression, anxiety, and stress scale, they had a lower goal subscale, again, reducing their overall therapeutic alliance. So there were some discussion about different diagnoses, such as people with anorexia nervosa, found it was easier to communicate and establish that alliance when they could use audio only. So for those that don't know, anorexia is an eating disorder. Since they didn't have that video or they weren't in person and the therapist wasn't seeing their appearance or how they presented and they just had to communicate with their voice, they found like it was easier to just only communicate verbally. Of note, a few times I read that the individual said that they were able to hide because they didn't have a video, which probably indicates that their symptoms were more severe and weren't quite really willing to admit the need to, gain weight or whatnot. It was easier for individuals to establish therapeutic alliance if they had less severe symptoms or they're more stable. People with depression found it was more difficult to establish the alliance. And this is why it was a little contradictory, because they felt that it was more difficult to communicate verbally. They couldn't rely on the nonverbal communication. One individual even used the word forced. It forced them to communicate. Whereas in the person in the room, the therapist would pick up on their nonverbal cues a little bit easier and bring them out of their shell and kind of bring that up and talk about that more. So the takeaway here, I just want to loop back with the internalizing symptoms. They recommended those with disruptive behaviors or externalizing symptoms might be more amenable to telemental health versus like the anxiety, depression, worrying person. Technology's role in telemental health. Clinicians reflected that they may have to extend greater effort if there's no established therapeutic alliance. Like I said, without the, physical contact, the need to simulate eye contact. And I do stress that specifically because when you're looking at your video, I think we're probably all used to this now on synchronous videos, but to simulate the eye contact, you actually have to look at the camera itself and not the screen. So then there's a little bit of a delay. It's not exactly like eye contact because the therapist then has to move their eyes up and down from the screen. So the actual image of the person is a little bit in their periphery. Some advantages to the using telemental health was that it increases the independence and autonomy for adolescents. Now they no longer require an adult or older person or caregiver to drive them to appointments. The adolescent can just sign on and kind of interact on their own with the therapist or provider and then end the call, which is what happens frequently with my appointments now as a psychiatric nurse practitioner with my clients. The parent might still be at work, but the adolescent is home from school and they just click the link and sign on themselves. It eliminates the transportation burden, including the time needed to travel. Adolescents don't have to leave school to even connect through telehealth, or they don't have to leave school early to get to the appointment that's a little bit later. They don't need to take a long break from their sports practices, that sort of thing. There's increased flexibility in scheduling. If the person can't make it one of those times, the therapist can offer a different time. And, since you don't have that extra time needed to travel, it's easy to quickly sign on and off. A 30-minute appointment takes exactly 30 minutes instead of the 15, 20 minutes to drive there, the 30-minute appointment, 15, 20 minutes to drive home. Barriers here are access to hardware, as well as high-speed internet. as I've discussed about the difficulty to decode the nonverbal communication. Many clinicians also reported increased distractibility and less commitment to the therapy session. When someone is in the room with them, the therapist can kind of call out, if you will, if that teenager is distracted. But now if the teenager is on the computer and they still have their phone there, they can easily look at their phone during this session. Another aspect too is seeing the person's reflection. This was captured in the literature. I've noticed it as well in my practice, but in the literature, it's more difficult for the adolescent to share negative emotions on their face if they can see that reflection back on them. I do believe some platforms have become more advanced and you can hide your self view now, but that was a barrier that was listed in some of the literature. One of the studies, I believe it was the King article, they compared to audio only synchronous speaking, like phone call, compared to chat, written communication. They did find that the video conferencing, the synchronous communication had higher session impact, higher therapeutic alliance, and more nuanced communication versus just like the written synchronous chat. So I thought that was important to note. One study, the Israeli study, also put out this new model. They called it a third-party model, and they felt like the computer was acting as an invisible third party in the room and the controller. They haven't tested that theory out in another study, but I thought that was important to note because there wasn't one consensus or one way to say that to discuss how technology or the screen really does play a role in this relationship now. For the theme therapeutic space and privacy, there was a discussion about this need for a neutral therapeutic space. So several teenagers that were interviewed stated that they liked how they were not in their home. Their home could be the safe place, but still they didn't want to talk about negative emotions in their home. They wanted to be able to go somewhere else that's not their home or school, not their parents' room. They could go to this neutral space, discuss hard topics, and then be able to leave. They also felt like their parents might overhear them. So the Allison study was at this unique position where they had established relationships prior to the pandemic in person, and then they were shifted to the telehealth encounters. So during the in-person encounters, 96 reported that their encounters were very private, as opposed to only 75% when they moved to telehealth. Some reports in the qualitative studies were fears that parents were, even though they left the room, they might be listening at the door. So they liked being able to be in their own separate space away from other people. So some discussion in the articles were that, being really mindful about where the technology is placed within the home, putting it in a separate room. For those that live in smaller spaces, have multi-generational households, perhaps having the family run errands during the session so the adolescent is the only one home, or if there's available a car, parked car, then the adolescent can go out there. Other barriers, this is widespread, not just with telehealth, but it's been documented in the literature about lack of alone time with the provider. There's not always enough time for the patient and provider to speak alone, even though that is best practice. That's what is recommended. But the individuals in these literature also mentioned how that was a barrier to getting some private space. And then there was some concern about the security of the platform itself, of the software. Although now, we all need to use HIPAA compliant software to connect with our patients, but that still was a concern that was brought up. And lastly, regarding appointment attendance, a few different articles discuss this. Um, uh, so according to the Fry article, they were more likely to continue treatment and keep attending appointments if they had established the relationship in person prior to shifting to telemental health. And they also found that they had higher bond and goal subscores on the Working Alliance inventory. So the higher scores indicated a higher level of therapeutic alliance. Uh, the show rate was about the same, about 81% between in-person and telemental health. They were able to track down those who did not show to their appointments, and they reported it was either related to a technological issue or an increase in functional behaviors, meaning the person was more likely to attend sports practice or go on errands, something that they were working towards in their goal of therapy, and they chose to engage in that instead of logging on to their appointment. Another mention with appointment attendance that really helped with the telehealth platform is that there was a reduction in the transportation burden, no longer needing to drive or take public transportation to get to the appointment. It's easy to just click a link wherever you are, try to get a private space, and connect with a therapist or provider there. Okay, for the discussion in the scoping review, essentially 3 of the 10 articles recommended a hybrid approach. I do want to point out again that a few of the articles were completed before the pandemic and were just one-time consultations. That was the goal of their study. But for those that were during the pandemic, they recommended either establishing the relationship in person prior to transitioning to telehealth, or if someone is more acute or having more severe symptoms, bringing them in person, even if you've met them several times through telehealth, to kind of just build that therapeutic alliance, get back on track with the relationship between patient and provider, and work on the goals. The issue with that, however, is for the rural and remote adolescent, telehealth has really increased access to care because now there isn't this transportation burden. But if they're not able to get to their provider in person, this kind of approach won't work for them. I will say as a practicing clinician, I am licensed in Pennsylvania. So my name is on a list for insurances so a patient will call their insurance to see which providers accept their insurance. So I can be connected with people out in Pittsburgh, for example. So if they're having that acute issue, they're not able to travel to me to Philadelphia just for a one-time encounter and go back to telemental health. So that is kind of a limitation against the recommendation. And then for privacy, there was this recommendation for mindful problem solving, offering alone time with the provider. You might have to do check-ins with the parent there, but then you can ask the parent to step out. There was this fear about like listening in at the doorway, use of white noise apps, especially if the adolescent has two hardware devices, like a computer and a phone. You can use the white noise on the phone. I know that's not available for everybody, but other ways to problem solve it is such as sitting in a parked car, if that's available, and the parent is inside, or they can swap, or family can leave the apartment or the house to give the person a little bit more privacy. I've seen clients while they're at school, so a guidance counselor will help set them up in a private space, that sort of thing. I do want to discuss the limitations here. There was only one randomized controlled trial, and even with that, there was less than 200 participants. The randomized control trial was also like a post hoc analysis, so it wasn't setting out to discover therapeutic alliance initially. Um, Only 3 of the articles we found occurred before the pandemic. Um, so, and most were during the pandemic. So there was this collective trauma occurring, and also telemental health it hasn't really been standardized. I think it's been 5 years now. So we've learned a lot of best practices and whatnot. But we were still learning at the time these articles took place. I do want to note there was also a lack of diverse representation. They were from 6 countries, but none from the lower middle income countries. Not many mentioned ethnicity or sexual gender identity. So we don't kind of know too much about those specific populations, which I think that we need to learn a little bit more. So that leads us to future research. We should continue to discover this in the post-pandemic era. Now that there is a choice between in-person and online, whereas many of the articles, there was no choice but to do online. Studies should also include a comparison arm, which wasn't done in many of the studies. Compare in-person to telehealth only, and more rigorous studies with larger number of participants. So thank you for your time. I'm open for any questions. Happy to chat some more. Thanks.
Wow, great. Thank you very much, Allison. And we do have a question. If telehealth is the only option for an adolescent, what strategies have you found most effective in building and maintaining a strong therapeutic alliance with teens during telemental health sessions, especially when engagement is low or distractions are high?
Thank you for that question. I guess I do try to use more of the preamble before the clinical work, try to get to know them as a person. I will say my background is fake right now, but most teenagers don't have access to that, so we can talk about what's in their room. I also think being direct is helpful, mentioning that they are distracted. It's actually quite easy to tell if a teenager or someone else is looking at their phone. I see a lot of working adults, and I can tell when they're writing emails, and not paying attention in the session. So I do bring their attention to that in a gentle way. So those are some things that I try to do.
So with that, the difference in connecting with the teen, sort of that teen age group, you just mentioned that you also work with adult, patients. So do you find that a huge difference in connecting with them because of their age bracket alone, or do you see any younger patients, younger than, say, the teen adolescent age group?
Yeah, it's really unique, and I think it needs to be studied more. And that's why I think it is the relational bond. It seemed like to me that the adult is worried more about time and taking off time for work, whereas the
Okay.
teenager, yes, they're missing school and sports, but it is important to them, but their concept of time, I think, is a little bit different. So it does seem to be more of a relationship piece, and not a prioritization piece. So again, trying to get to know them, like, I don't have any dogs in the house right now, but that can be an icebreaker, like sharing things about yourself, I think helps. If the provider's like a little bit vulnerable, then the patient might be more vulnerable too. As for the child, that's its own unique experience.
Okay.
In person, the parent does most of the talking for like the school age child, and the child might be off playing in the office. I found in telehealth, the child often wanders off of the camera in and out of the room and kind of playing. So you do need to like call them back and get their attention. But I think because the parent's there, most of the whole time, it's mostly two adults speaking.
Gotcha. So did you find, with regards to back to your privacy issue, I was thinking, other ways of connecting, headphones. You know, granted, if there's a fear of somebody overhearing the conversation, they're going to only hear half of it. If you've got headphones on, as compared to having a computer and your speakers are on, that makes a lot of sense. Finding a car which you can close, you can kind of control what's going on around you then for that quiet space. But that gets that can be, I can see how that can be such a challenge. But adding that technology piece of maybe some headphones or AirPods or whatever devices, to help at least minimize that overhearing.
Yes, I'm so glad you said that, because it reminded me with that, we're supposed to use a mix of open-ended questions and close-ended questions, but if they have their AirPods on, you can ask specific close-ended one so the someone overhearing doesn't hear the question, but just hears yes or no. Um, so that can be a way to discuss some tricky topics without being overheard. So, yeah.
Well, that way you can also communicate, okay, we can, they may let you know that, yes, there's somebody within earshot, and then you can switch how those questions are going because they're just hearing the question. That's a unique way of making sure you're paying attention. And I would think understanding that and letting them know that, no, this is a safe place, and I'm going to ask you questions that is not going to reveal what we're really talking about then, and
Right.
creating a little bit more therapy access that way. Our uh so another comment was, thank you for the answer to the first question and the emphasis on the importance of hybrid care. Here's another question. Have you ever used chat function for conversations that truly need to stay private as well while you're in your sessions?
Yes, I have. So yeah, I'm glad you all are asking these questions because I forgot to bring it up. Yeah, that's another way to problem solve the privacy issue. Absolutely. Yes.
And I suppose on a phone makes it a little more difficulty doing your texting. But again, as an adolescent, this is a generalized statement. They can text pretty fast. Sometimes it's its whole a different language. Um, on another question, kind of on that, are there particular tools or platforms that enhance the therapeutic alliance in a remote setting with teens that you found?
I've not seen that discussed in the literature. I've used three different platforms. I haven't found any to be particularly more helpful.
Okay,
That I think that's a really good question though.
gotcha. Let's see, what else? I was making notes while you were talking. Going back to your anorexia, and you were talking about how in that particular diagnosis, they were likely to be more connected with the telepiece because they could hide. Is that possibly because like a self-image issue and not having to worry about, how they look, which is that's part of that anorexic nervosa, issue with them?
Yes, that was my interpretation. The literature didn't spell that out outright,
Okay.
but that's because there are a few different articles that mention that. I think that's probably has to do with that.
That
Uh,
that would make sense. Let's see here. And depression, that was the one that was kind of a less um, it had a little bit more negative connotation of using the telehealth with regards to a depression. And is that maybe because it's just harder to make that connection with the therapist? And how do you, I mean, the challenge of making that connection so they can be vulnerable and feel like they're not alone with their internal thoughts. Is
right.
that
I think that's part of the nature of depression is wanting to self-isolate and withdraw. And part of treatment is encouraging social interaction. So I think that takes time. The more frequent the interaction takes place, with therapists, that's often weekly or twice weekly.
Mhm.
With prescribers, it's less frequent, but I think the more often it's done, that can help build the relationship, even if it's through telehealth.
Do you ever do like a group session with the family, with the adolescent and a family member? Or is it usually just focused on the teen themselves?
Me personally, the majority of my sessions are with the parent present
Okay.
too. I do ask the parent to step out. I guess that's the tricky part with the
Okay.
privacy piece. But yeah, because I need the information from the parent, especially if the teenager isn't volunteering it.
Gotcha. That makes sense. Okay, so that goes on to some of your pre-appointment permissions. And part of the literature you're talking about how adolescents can connect, say like while the parent is still at work. So is there um, a pre sort of a documentation of that if they're under the age of 18 that they can still meet with their provider without the parent present or signing them in?
That has to do with the age of consent.
Okay,
So in Pennsylvania, the age is 14. In New Jersey, I'm also licensed in New Jersey, it's 16. So if they're under that, the parent, I don't believe it's written into the legislature, but the parent can be in a separate space but log in onto telehealth their own. Most of the time for people under 14, I'd say they're in the same room, but
gotcha.
yeah, that's one way
But that
around.
can get kind of you got to make sure you're understanding, especially with cross-state licensure, then what state you're working in. Okay, that makes sense. I just know that in telehealth, making sure that there's permission. Yes, you agree to utilize a telehealth, especially in the adult, with adult connections. There's that acknowledgement of yes, we're using telehealth, and they have a choice that they can use that or not. Um, let's see. And then any other workarounds that you have found, maybe even your own experience when you've got broadband issues, or did any of the literature talk about, potential workarounds? Yes, you have voice and video like we have today, even in our own experience with the Arizona Telemedicine Program and SWTRC, we'll get bandwidth issues and like, okay, go ahead and turn your video off. So we can still continue to hear, the presenter, but we won't necessarily be able to see them. Do you have some workarounds that you've had to deal with on your own with that?
Yes, I've had to do that as well. What is tricky for me is sometimes their internet isn't as stable, so I can't see them. They can see me. I'd much rather it be the other way around. I know they're probably more comfortable being able to see me, but part of my assessment is observation. But yeah, so we do have to do some workarounds with that. Maybe we could see each other visually for a few minutes and then we have to switch to audio. But that happens. And then always having like a backup phone to call if we need to like completely drop the platform.
Gotcha. And I know that with especially cross-state licensure, an emergency number isn't necessarily the phone number. You got to make sure the emergency number of where they're actually living is going to actually connect to services, correct?
Yes, yes. And actually, that's a good point too. I haven't found this in the literature, but my own best practice is I always ask the location where they are right at that moment for emergencies. They don't quite understand why I'm asking that. They'll give me their home address when it's clear that they're in a car or at school, but I do ask where they're physically located, just in case there's like any suicidal ideation or a medical emergency or something.
Gotcha. That makes a lot of sense. All right, let's see here. I think that takes care of some of my questions that I had. I greatly appreciate the information. Doesn't look like we have any more questions in the chat. We've got just a few minutes left. Everybody that has joined us, please go ahead and do the evaluation at the end of this. You'll also have a question in there that asks about what else would you like to hear about. Please let us know, and we'd be more than happy to, either bring Ms. Urkel back or we find another presenter with different topics. What we always love to hear from our attendees. Um, and before we sign off, Allison, is there any other kind of closing remarks that you would like to say about your research?
No, just really thank you for your time. I'm looking forward to in the next few years as more literature comes out about how we can really improve the therapeutic alliance with teenagers, what best practice takeaways we can do to really support them to get their needs met.
That is great. Unfortunately, I think that's a population set that just really needs a lot of support, especially at their age with everything else going on in their lives as they're growing up to be the future leaders of our country, right? All right, everybody. So Allison's presentation is going to be listed on our website. I will have that in the thank you email. We've got this recorded. You'll be able to review the webinar, all the questions and the chat that we've been having, and plus see her slides as well. So I'm going to go ahead and give everybody back 10 minutes of their time. Thank you again for joining us today, and we look forward to seeing you at another future webinar. Thank you, everybody.